Good afternoon, everyone, and welcome to today's webinar, Connecting the Dots, What Will It Take to Meet the Challenge of Migraine? My name is Ana Briceño. I'm the Senior Director of Communications at Research America, a nonprofit advocacy alliance. I am joined by Cherry Schwartzbeck, our Senior Manager of Communications.
Hello, everybody, and welcome.
Before we get started, I'd like to go over a few items so you know how to participate in today's event. You're listening via your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio panel and the dial-in information will be displayed. Today's webinar will be recording. You will have the opportunity to submit questions by typing into the questions pane of the control panel. You may send your questions in at any time during the presentation. We will then collect these and try to address as many as possible during the audience Q&A session at the end of today's presentation. We have three outstanding speakers for you today. For our first presentation, I would like to introduce Alicia Torborg, Executive Director for the Association of Migraine Disorders. Alicia is also a migraine patient. She's going to kick off today's webinar. Alicia?
Thank you very much for the introduction. I'm happy to be here. So I'm going to start with some statistics. Many of you on the phone or on the line may be familiar with these, but I will run through them quickly. So approximately 39 million Americans are impacted by migraine disease. 10% of children have migraine. 50% of those with migraine are undiagnosed. 50% of those being treated for migraine are unhappy with their treatment. Migraine disproportionately impacts women. 70% of the patients are women. And migraines are most prevalent during the most productive years of their life, which is typically 25 to 45 years old. Next slide, please. So I'll start a little bit with my migraine history. My migraines began when I was 10 years old. They were frequently and really disabling. They would start with an aura where it would impact my vision, and eventually they'd get so bad that I would be sick, oftentimes vomiting, for an entire day, writhing and crying in pain, along with difficulty speaking. Oftentimes, my parents would take me to the doctor's office or hospital, where I would beg for a shot. They used to give me a shot that would just simply put me to sleep for a while. I could always count on having a migraine hangover the next day. I even remember trying to make a deal with God, saying, please, let me break a bone instead of having these terrible migraine attacks. This picture was from a family vacation where my family rented a beach house. Went from having a great time to all of a sudden getting a whopper of a migraine. My parents had to stop a 4th of July parade that was happening and take me to the hospital. I lost about 2 days of that vacation because of the migraines. As I got a little bit older, I determined what my triggers were. I was able to eliminate many of them, which was difficult as a teenager, as a lot of teenagers love Doritos, chocolate, and caffeine. But I found that if I avoided the triggers, I could somewhat manage them a little bit better. Next slide, please. Fast forward to my late 20s. It was in the 90s. I was a vice president and mortgage banker during the housing boom. This was a really stressful environment. It was really busy and expectations were really high. On top of that, I was newly promoted to that position and I was pregnant with my second child. When all of a sudden the migraines came back, they were terrible. They came back with a vengeance. And I was unable to take a lot of my rescue medications. As a young woman, I never wanted anyone to know what I was going through. I thought it would make me seem weak or unreliable. At one point, my husband brought a couch into my office so I could turn off the lights, lay down for a bit, and pray that the pain, would go away. It was really, obviously very difficult. Thankfully, after I had my daughter, the migraine subsided. Next screen. So migraines at midlife. These were a new shade of migraine for me. They came back with a vengeance. I was about 45. So you might start to notice a trend here with hormones. They started at adolescence, got worse during pregnancy, and then perimenopause. But now they're different. And I'm fortunate in a way that I no longer get the aura and the vomiting. But these headaches are terrible in that they can last for 4 or 5 months at a clip. Every single day, some level of pain. I'm healthy, I'm strong, I'm independent, I'm very active with my family and my community. I'm an athlete. I've completed in triathlons, Tough Mudders, extreme bike rides, all different types of races. But these migraine attacks just wear me down. They take a toll. Eventually, I had to bow out of many of the events that I really enjoyed doing and were such a big part of my life. But migraine impacts every part of my life, my family, my friends, and work. They're absolutely overwhelming and debilitating. Next screen. So over the years, I've seen chiropractors, neurologists, acupuncturists, yoga, diet changes, allergists, ENT. I've been in the hospital. I tried natural remedies. I've had over-the-counter medications, vitamins, triptans, beta blockers, tons of medications, even barbiturates. My primary care doctor said they're tension headaches. He prescribed something that didn't work. Most recently this year, and this is significant, this year in 2018, I saw someone who was listed as a headache specialist, and he had never heard of CGRP blockers. And for those of you who have migraine or are involved in migraine in some way, most everybody has heard of this because it's groundbreaking. But so anyway, one of the doctors that I saw over all these years happened to be an ENT. I was thinking or hoping that maybe I was allergic to something. There had to be something tangible in my head that was making this happen. Who would think that an ENT would be the one who re-diagnosed me with migraine, because we didn't think these were migraine anymore. So he did all of the usual allergy testing, but he was the first doctor who spent a significant amount of time with me and asked me a ton of questions. And as part of this questioning, we discovered that so many of my symptoms, they were random, like strange symptoms, phantom smells, congestion, balance issues, trouble speaking. These were all related to migraine. So that was, again, my official diagnosis, although they were just so different from how they were in previous times of my life. But together we found a cocktail of two different medications that seemed to help. However, I would still have these episodes when my head pain would not go away. And then finally this year, like I had said before, the CGRP blockers came out, and this was a huge game changer for me. I was on my 5th month of having a constant migraine when I took my first dose. And in the past 4 months, I've only had 14 headache days, and most of them were pretty minor. So like I said, this was a game changer for me. But there are so many people out there that are not as fortunate as I am. And I am fortunate. I know I am, but there are people out there that are much worse. Their head pain and their symptoms are just so much worse than mine. They're disabled, they're suffering, and some have even taken their lives. Next screen. So I've told you about me being a patient. Now I'll segue into being the executive director for the Association of Migraine Disorders. And while there's been a lot of advances in treatment in the last year, much more work needs to be done. There's still millions of people around the world that are suffering from this debilitating disease. And as I mentioned earlier, only about 50% of people with migraine have actually been diagnosed. Teachers, coaches, employers, and clinicians, they need to know more about this disease. So one of the things that we've done at AMD is we've developed this 3-module course. It provides education to all types of clinicians on how to diagnose and treat migraine. And we're also working on making kind of a version of this for the general public as well. But the goal here is to get more people educated and upskilled how to identify, treat, and diagnose migraine. So research. There's a lack of researchers being attracted to migraine as a topic and a career. But there's been an increasingly coordinated effort to fix this problem. Headache on the Hill has done a great job of increasing, first, the awareness that NIH was neglecting headache as a neurological disease, and then arguing for increasing funding. And with increased funding available, the challenge now is to educate the basic science community. And at AMD, we've taken some steps to that end by hosting the first annual Migraine Social at the Society for Neuroscience this past year at their annual meeting. And now with the help of the American Headache Society and Headache on the Hill, we hope to introduce a migraine symposium at next year's meeting. Next slide. So AMD is also working with the Migraine Research Foundation to develop seed grants for migraine research and for a new series of impact grants. It's $200,000 over 3 years, and it'll answer specific research questions. One grant is to study the dosing of cannabinoids, and the second impact grant is hormonal effects on migraine. And finally, AMD is launching a new interdisciplinary migraine research roundtable, and that'll be held in Providence. I'm pretty sure at Brown University on March 31st. And there'll be 12 participants that'll be attending by invitation only. And so that concludes my talk.
Alicia, I just want to thank you so much for your time and really walking us through and painting a vivid picture of migraine patients and their quality of life, particularly sharing your journey with the diagnosis and matching with the right provider. So thank you for that. Now I'd like to introduce our second speaker, Lindsay Videniak, Executive Director of the Headache and Migraine Policy Forum.
Thank you. That was actually very good. Hi, everyone. First of all, thank you to Research America and your team. This is an incredibly important topic. Everyone on this call, there's a good chance that most of the folks here know someone with migraine disease, or their patient themselves, or caregivers, and so this matters. My best friend is a migraine patient, and when we were roommates, I remember often her having to retreat to a dark room, miss work, and we were in a pretty male-dominated profession, and so there are challenges, especially for women with this disease state. So thank you for the opportunity. The Headache and Migraine Policy Forum is really a convener and a coalition group that's made up of a lot of the stakeholders in this community, of folks who are disproportionately impacted, women's health groups, veterans. You heard Alicia talk about some of the statistics there, as well as migraine advocacy groups. And so we convene to address policy issues, and that may be on the state or federal level. And so, I was excited to be asked to talk about what we see are the sort of challenges and opportunities going on right now in the current landscape. And so just to kick it off as a broad overview, with new therapeutic options comes a lot of excitement, but also perhaps a knee-jerk reaction from some parties to restrict access. And so I'll speak in a little bit more specifically about what we're seeing in terms of prescriber restrictions, but broadly speaking, we're already seeing instances where patients who are excited about trying a new therapy are not able to access it. The second topic that we are working on is the lack of headache specialists, and I'll speak more to that in a little bit. And then really as both a challenge and an opportunity, the fact that there are multiple therapies coming to market all at once. So, our view is more therapeutic options is better than fewer options, but in some cases, that means some are oral therapies, injectable therapies. It's a multimodal environment, and so understanding that every patient is different, that may lead to confusion and some sort of lack of understanding in how to treat every patient and not just put them into a single bucket. And so we're addressing that. Combination therapy questions and opportunities, that goes back to what I just mentioned about sort of it's not one size fits all. This is an incredibly heterogeneous patient population. We recently spoke to a group about what migraine freedom means for individual patients, and that really can be different for each person. And so that's certainly an issue. And then finally, as Alicia pointed to, there's a stigma to this disease, right? So, 75% of migraine patients are women. We know that, there's already a pay gap in the workforce, so women are perhaps less likely to talk about the issue for fear of reprisal or people not understanding or thinking that it's just a headache. which is a phrase that you hear. And so these are all challenges that we see. Okay, next slide. So anticipating access challenges or access barriers, going back to what my first point was, why do we think that these new treatment options will likely be out of reach for some patients? Next slide. Next slide. So we already know that step therapy and fail first practices are, oh, can you go back one, please? We already know that step therapy and fail first, which really is the practice of beginning a drug therapy for a medical condition with the most cost-effective drug, and then progressing to other more costly or risky therapies only if necessary. That can have implications for migraine patients who are already in pain. They are already having to wait. They may have to try multiple triptans. We know that this utilization management barrier is already being utilized in the neurotoxin class. So we anticipate, while it's not occurring quite yet, unless it's included in the formularies, having to have gone through triptans first, we can anticipate that this will likely be an access barrier in the CGRP class. And so before we move ahead, I would also add that and I don't have it listed here, but we anticipate that prior authorization, which is the practice of making sure that your medical provider gets prior approval before prescribing a therapy, we anticipate that will also likely be an issue in the future. Okay, next slide. So back to prescriber restrictions. So, the issue that we've come across really is that the patient can receive a therapy if they can find a provider who can actually prescribe it. So, there was some of the folks on this call may be well aware, there's a Reuters article earlier this year talking about how Florida Blue, for example, had restricted access to only those providers who were UCNS certified headache specialists. And so for a state like Florida, where there were only 25 of these individuals, that meant one for 90,000 migraine patients. And so, we personally find that unacceptable. We've engaged with the Florida Division of Consumer Affairs and opened essentially a complaint to talk about the sort of hardship and burden that this means for migraine patients who would have extremely long waiting times. They would months that they would have to wait for an appointment. And so we see this as a chilling effect on migraine patient access. Next slide. Next slide. So this is essentially what the prescription says, or the prescriber restriction says. Your doctor, and we know that many migraine patients see a primary care physician, is not able to prescribe the targeted migraine medicines without being either a neurologist, a headache specialist, or one of these UCNS neurological subspecialties. Another example that we've also shared is, and we're submitting a letter today to Kansas DCBS on the same issue. They are requiring a UCNS certified headache specialist to prescribe, of which there are none in the state. And so that's obviously that's not acceptable. And so we're working with Kansas DCBS on that issue. Next slide. But the other part of this that kind of gets lost in the fray is that because really this slide says 416 specialists in the U.S., really I'd like to say less than 600 certified headache specialists, because there's several forms of certification. What this means is that there's such a small pool of individuals, and this is a historically challenging disease to treat because of the stigma we talked about, because of lack of biomarkers and research support, that because you have such a low number of physicians and specialists who are able to prescribe, this leads to burnout, fatigue. You think about the staff that's involved in having to to address a large patient population because it's such a small number of folks. And, we also know that neurologists in general are the third highest of all physicians to experience burnout. And so we know burnout has a long-term effect on patient care. It may mean that there are fewer people who decide to go into headache as a specialty. It may mean that some patients simply give up. And so that this is a real systemic problem that many groups, including the good work at AAN and AHS, are trying to address. And we'll speak a bit more about what we understand their efforts to be a little later. Okay, next slide. Next slide. So some of the factors, can you go back one? Some of the factors influencing the lack of headache specialists. So we talked about the physician burnout and fatigue, and the recruitment of clinicians because the fact that this is going on. I would also say that because there have been historically a lack of treatment options, for those physicians going into clinical practice, they may have not felt the need to go into headache as a specialty because there were fewer ways to effectively treat their patients. They went into medicine to care for people, and so that may have been a detractor. But the other component of this, and Alicia kind of touched on it, was NIH funding challenges. And so Headache on the Hill, the effort that she described that is undertaken by the Alliance for Headache Disorders Advocacy, they bring folks to Capitol Hill to really talk about the need for increased NIH funding. But, and I don't have a special slide for this, but, the scale of disease burden is truly underappreciated. There was a global burden of disease study recently that pointed out that headache disorders are the second leading cause of global disability in the world. And so we agree that NIH funding for headache disorders research has not been commensurate with its burden. In 2017, the last year that numbers are really taken, we know, for example, that there were 315 principal investigators at NIH for epilepsy, but only 53 for headache. And so what that means is that headache disorders are 3 times as burdensome as epilepsy, but only receive 1/6 of the number of principal investigators at NIH. And so we think that needs to change, and we think that NIH needs to more sufficiently prioritize headache disorders research, and that includes making sure that new investigators enter the headache field in response to their initiative. So we're supportive of that. Next slide. And so going back to some of the misconceptions about current treatment options, the migraine community underwent a pretty robust ICER review earlier this year, and there were a record number of patient comments due to the great work of folks like CHAMP. We helped sort of convene the group and made sure that we had 6 very formal letters that we submitted to ICER. But our role really was to talk about the fact that the migraine patient is not one bucket. There are chronic patients, there are episodic patients, there are highly episodic patients. But the point is, when you're valuing new therapeutic options, one size does not fit all. And so that is a message that we think that ICER heard, and we had a largely positive outcome. We were pleased by that. We hope that insurance companies will look at that review and see how robust it was, and that it can really inform them in their decision making about their formulary issues. And so the community is very active, but that's the big point about therapeutic options. One treatment option will not work for every one person. And so that leads the second point. There is some patient confusion about programs, therapies. There's so many new coming onto market. So groups like CHAMP are undertaking efforts to make sure that patients, from a patient perspective, understand the differences within the class. And so the other last misconception, I always have to add stigma about the general public. We talked about that, and employers, and as Alicia talked about, what reasonable accommodations can be made, and along with therapy. Next slide. So what can we do about it? Okay, so from our perspective, we take a campaign-style approach. When we see a policy issue, we engage the community, we learn about the issue, and we engage with decision makers and policy makers. So in the case, for example, of prescriber restrictions I talked about, we sent a letter. We work closely with patient-centered groups to identify patient advocates in the migraine community who can really be storytellers. It's one thing to have the data, but having the data combined with a personal narrative we think is very powerful. And so for all migraine patients who may be on this call, I would say to you, please Google or you can go to our website and we have a direct banner to engage and join CHAMP or GHLF, who can work with you to identify advocacy opportunities. HMPF is an integral part of Headache on the Hill. Our partner group, AFPA, helps schedule those Hill meetings, and that would include helping to promote shifting of the federal pay line towards headache and migraine disease funding. We are also going to be holding a policy luncheon on migraine and disability in mid-February. We also would promote patient-centered models, and so that is a broad category, but really anything that sort of may put the disability-adjusted life year ahead of the quality-adjusted life year in a value assessment proposition. It takes into account things like societal burden and other presenteeism, absenteeism, and not just the clinical trials research. As far as advocating for primary physicians to prescribe, as I mentioned, we are doing that on a statewide basis to make sure that migraine patients have access to treatment options from the physician that they trust. And then we just want to give a shout out and encourage AAN and AHS efforts to increase fellowships in headache. We think that's incredibly important. That will help relieve the backlog or increase the pipeline for headache specialists to treat patients. And then the last two things are really sort of a personal note. Talk to more people about your migraine disease. There is a stigma, and as long as folks are not as comfortable in talking to their loved ones or their close friends about it, it is an invisible disease, but it's one that is becoming more out in the open. And so we try to break down those barriers through partner groups like US Pain and other groups who really try to shine a light on this being an invisible disease. And then finally, don't take no for an answer. I think that sometimes a lot of the access challenges that we face are put up as barriers, but that if we can convene the right folks around the table, we can find solutions. So that concludes my remarks, and thank you for the opportunity, and I'll be happy to answer questions at the end.
Lindsay, this is Anna. Thank you so much for sharing your insights and expertise on some of the limitations that there are with prescribers, and reminding people that there's not a one-size-fits-all approach. And particularly powerful, your next step slide that you just concluded with, to give people some ideas of where to go next. So I will say that Research America has been conducting a series of webinars and programming around migraine this year, and we have invited the NIH to provide some insights on what they're doing to work in this space. So I'd invite listeners on the webinar to go to our website and learn more about what the NIH is doing to further migraine research. And now I'd like to turn it over to our third speaker today, Dr. Suchitra Iyer from the Center for Evidence and Practice Improvement with the Agency for Healthcare Research and Quality. Thank you, Dr. Iyer, for joining us today.
Thank you, Anna, for the invitation. I really appreciate the opportunity to share what AHRQ does and the unique niche that we have within HHS. We are a little known, CMS, FDA, and NIH are our better known siblings. So I really appreciate the opportunity to share with us some of the good work that we do. So I'll begin with a general description of our goals and programs, and then give you some specific examples of the things we do. So to start off with, this is our mission statement. So our mission is to work in partnership with other federal agencies and the public to ensure that evidence is understood. And the goal is to make healthcare safer, higher quality, more accessible, equitable, and affordable. Next slide, please. So our approach has been to invest in research and evidence to understand how to make healthcare safer and higher quality, and use that information to create materials that will help train professionals in the healthcare system to translate our findings from the evidence into improvements in healthcare. Next slide, please. So in essence, AHRQ's efforts have been to be a bridge to close the gap between research and practice. And AHRQ creates tools that take the what and translates it into the how by again empowering research providers, that's doctors and other healthcare providers, to improve care. Next slide, please. Next slide, please. Oh, so I'm sorry. Could we go back? No, you're right. You're fine. This is the right slide. I think I'm seeing a little lag on my computer, so I'm sorry if I sound impatient. So, one of the tools that AHRQ uses and is what we consider a foundation stone and the bridge to close the gap between research and evidence, and that is an evidence report. What is it? It's not a quick Google search. It's a type of a literature review that summarizes the literature in the peer-reviewed literature using specific methods. Next. So a systematic review does an evidence report does a systematic search of the literature. It assesses the quality of the individual studies, and it summarizes all the information into a coherent report, and then indicates the confidence in the findings and shares that information with folks to let them know what works best for whom and under what conditions. So many people think that we do primary research, and evidence reports are not primary research. They are not clinical trials. What they are is a collection of findings from various clinical trials and clinical studies that are condensed into a single report. So what makes our evidence-based practice program so special? So next slide, please. So we have a proven stakeholder-driven process to identify topics. We speak to researchers, clinicians, patient advocates who help us, who participate as key informants on our projects and help us underscore the questions that we should include and what aspects of a particular topic we need to focus on. We apply scientifically rigorous methods, as I spoke about in my previous slide, to collect the evidence, and perhaps people come to us because they trust our work. And some of the examples why that may be is because we include a process of evaluating conflicts of interest of all people that are involved in creating our reports. We have public comment periods that collect feedbacks from members of the public on all draft reports. So this independence and unbiased transparency is what sets us apart. Our processes reflect current standards that exist, that were set by the Institute of Medicine in 2010, which is now, of course, called the National Academies of Science. Next, please. So this slide sort of tells us who, lets you know who we work with. So we have worked with a number of federal partners that includes both agencies within HHS and without. And we've also worked with other professional societies like AAN, the American College of Physicians, that mostly consists of internists, AHRQ, the American College of Obstetrics and Gynecology. And whenever the professional societies are interested in putting out guidelines, everyone now understands the necessity for evidence-based guidelines. Our evidence reports have formed the basis for many a guideline. And I'm happy to share details with you later if you have any questions. Next, please. I just wanted to share that we have in the past done systematic reviews related to migraines. I'm not going to dwell a lot on this slide because the information in these reports is now definitely outdated. It's about 6 to 7 years old, and as you all know and appreciate, and that is really outdated. So, but I'm going to use this just to let you know that we have a broad interest. Next slide, please. More recently, HHS has been focusing on the opioid crisis. And as part of the 5-point strategy to combat this crisis, where we at AHRQ are looking into better pain management. And in that context, the most recent report that we have put out, next slide, please, looks at various non-invasive and non-pharmacologic interventions to treat chronic pain. Now, we did have a stakeholder panel that informed us of the most common conditions, common chronic pain conditions that afflict folks. And unfortunately, migraine is not one of them. Chronic tension headaches are. But this is just to let you know that we are very interested in treatment of chronic pain in general and looking at better pain management using opioids, but yet at the same time ensuring that they are prescribed only when appropriate. Next slide, please. Some of the more recent reports that we have partnered with the CDC look at non-invasive, non-pharmacologic treatments. It's an update of the report we had done previously. It looks at other opioid treatments, as well as non-opioid pharmacologic treatments, which could be, anticonvulsants, SSRIs. So these are projects that we have just kicked off, and please look for our reports when we post them for public comment in the near future. Next slide, please. So Okay, so AHRQ has recently put out a call for promising patient-centered outcomes research findings with the potential to improve patient healthcare outcomes for dissemination and implementation into clinical practice. So I'm really happy to have gone through it because both Alicia and Lindsay have said that there is a lot of evidence, but that evidence is really not helpful if it is not being disseminated and implemented into practice. So anyone can submit a nomination to the D&I initiative at AHRQ, researchers, consumers, advocacy organizations. So if you have a particular evidence-based intervention that addresses patients with migraine, please look us up on our website and send us a nomination. It'll get evaluated against these standards that are on the screen. So it's assessed for strength of evidence. We use a multi-stakeholder panel to help us assess the feasibility and explore the range of potential approaches, and really looking for widespread dissemination of the information that can help improve patient-centered outcomes. And note right at the bottom is we want to evaluate that to make sure that it has impacted and made the changes that we had hoped it would. Next slide, please. So I'm going to give you a few examples of projects that we have done at AHRQ, and they are specific. They have they are not specific to migraine, but I invite you to take off whatever condition I'm talking about and plug in migraine, because you'll see that it's very widely applicable. For instance, our health IT division has recently created an interoperable clinical decision support system to help physicians help their patients who have chronic pain. So what it essentially is an app which appears as a dashboard within an electronic health record for a patient, and it consolidates onto a single viewing screen all the data that is necessary for a physician to help the patient sitting in front of him. Next slide, please. So this is an example of some of the information that is available on that clinical decision support. So it looks at prior treatments, other drugs that patients are taking. And while it doesn't make recommendations, it offers all the information to the clinician at the fingertips so that they can use their expertise and their experience to guide the patient in the right direction. Next slide, please. So I'm using this example of treatments for opioid use disorder to say that currently there is some evidence that there are certain efficacious medicines that work to treat opioid use disorders. However, that information is not easily available, and there are several models of care that just remain inside reports. So AHRQ is very interested in funding and partnering with organizations who will take this evidence out into the field and let primary care physicians, who are the first line of treatment for patients, know that there are medications that are available and how to prescribe them. Next slide, please. So AHRQ recently supported another initiative to disseminate and implement findings from a recent report on unhealthy alcohol use in primary care. Again, you can take off the words unhealthy alcohol use and put in migraine. So essentially, this particular initiative looks to implement patient-centered outcomes research in the field. What is well known is that brief screening interventions and medication-assisted therapy helps identify and treat those who have alcohol use disorders. And this is an effort to empower the primary care physicians so that the patients are not shuttled off to the next step, to see physicians. And this goes back to the points that were made in previous talks, where some primary care physicians are more available than a particular specialist. As in Florida, there were only 25. So why not empower the primary care physician with the ability to treat the patient with the information available either through clinical decision support or other means or other education means by which. So we are able to support these efforts through grants and contracts. Next slide, please. And this is to underscore that AHRQ is really committed to transforming care for people living with multiple chronic conditions. We recognize the fact that many people don't have just one condition. It's not just the migraine. It's several other issues that folks are battling, be it hormone-related or otherwise. And we are committed to whole person care that is not just treating the disease, but the person, recognizing that they may have other issues. Next slide, please. So I wanted to share this model that was recently published. So the Learn and Care model highlights the two key functions of the system, which is to care for the individual and to learn from that experience. We understand that patients don't live in isolation and they interact with their communities and their surroundings, and that is the context in which we hope that patients will be treated and cared for. And when one patient with a migraine comes to see a primary care physician, what that patient learns, what that physician may learn from that patient could inform the way the patient or the system treats the next patients, or understanding that each patient is different and a one-size-fits-all approach may not be the best. And this again is highlighted by Alicia and Lindsay, who went ahead of me. Next slide, please. So I'm coming to the end of my talk. I want to leave folks with the idea that, you know, we are very interested in the patient. We have worked in the past years and continue to focus on improving the lives of patients. Everything we do keeps the patient at the center of our universe. Next slide, please. And we do this by helping healthcare systems and professionals deliver care that is high quality, safe, and high value. Next slide, please. So I'm going to leave you with the thought that AHRQ, through healthcare systems research and practice improvement and data and analytics, aims to help healthcare systems and professionals improve quality, safety, and value of care to improve the lives of patients. And I think I'm going to end my talk with that. I think we're having all questions at the end.
That's correct. Dr. Iyer, thank you so much for telling us all about AHRQ and the work to improve care and close the gap between research and evidence, and particularly underscoring your point that there are meaningful ways to engage with AHRQ, and all those researchers on the call or interested in more migraine research to contact AHRQ and really drive home the point that it's important to just not only care, but to learn from those. And your point about empowering primary care physicians is, I think, just a really key point here throughout all the talks. So thank you. So now we're going to move to the Q&A portion of the webinar, and I do have questions for each of the speakers. So the first question is actually for Alicia. You mentioned in your experience as a patient and being at work, and that your husband, I think it was, had to bring in a sofa for you for your office to have that time to manage your migraine as best as you could. Can you talk a little bit about, the work accommodations did you ask for them? Was that available to you? Just some more about your experience related to that.
Sure. So I think our culture is a little bit more friendly and open to it now than it was, 17 years ago or 20 years ago. And I think in all aspects, I think as far as health, I think we've made advances culturally for women too. So, for example, often today you'll have mothers' rooms, nursing rooms, where women can go who are still nursing. There are, and that wasn't even thought of, 15 or 20 years ago. But there are simple changes that can be made in the workplace, and it's really getting that out there. A lot of corporations don't even know what they can do, but having quiet areas, having flexible work options, or working from home. If I had a migraine now, I might be unable to work in the morning, but if I sleep for a little bit, maybe I could work from 1 o'clock till 6 at night, or, throw in a couple hours at night. There are things that businesses can do with overhead lighting, quiet areas, trying to limit odors and scents, asking people not to wear colognes or perfumes. So I think we're making progress. There's a lot more work that needs to be done. There's a few organizations, AMD is one of them, within the CHAMP group, and we're trying to come up with a migraine wellness package that we can get out to larger corporations that will really help those with migraine in the workplace.
Great, thank you for that. I don't know if, Lindsay, you have any additional thoughts on that particular topic.
No, I think that Alicia covered it well. We certainly are a member of CHAMP, and we would support that effort. I think that there is a disconnect between what larger employers or mid-sized or smaller employers and HR professionals see as reasonable accommodations, right? Like things that they can do, quite frankly, quite cheaply in order to accommodate migraine patients. And so we look forward to working on that as well.
So Lindsay, the next question is for you. You gave an illustration about Florida, about there's only 25 headache specialists. Is that correct?
Yes, 25.
Yeah. So obviously that's a huge gap between the amount of patients and the actual headache specialists. And you talked about some of the things that your group was working on to really overcome that. Are there any states in the U.S. that are doing this really well? And what can we learn from that?
Yeah, that's a really great question. It's so new that unfortunately we're just seeing where there happen to be hotspots and access issues. But I think that's a good point where we can identify states that are sort of not putting up these initial restrictions. I think that, when you have a state like Florida, where Florida Blue has 30% of the market share, unfortunately, that's a large state, and then that's one insurer that has a large segment of the patient population, and so that's really not a best practice. But that would be a nice offset if we did examine, is there a state that's doing it better?
Okay. The next question is for Dr. Iyer. You mentioned that AHRQ is really focused on pain management. Are there any particular activities in the upcoming year or initiatives that AHRQ is taking on in this space that you think is important for researchers to know about?
I think stay engaged. We welcome comments. We want to know when we post the protocol for our systematic review on methods to use or what outcomes we think are important or what interventions are important. I think we'd like to hear from you to let us know whether we've thought about it carefully, if our group of stakeholders have informed us adequately, or whether we should be thinking of something else. So there are two, and maybe I should also add, currently, for this set of reports that are ongoing, we'll be seeking input on the draft report. But there will be opportunity for other upcoming reports for folks to participate as key informants, where folks can even send us ideas for systematic reviews. We have an active nomination portal where we welcome topics. Advocacy organizations could partner with AAN. We, of course, are very interested in making sure our evidence then gets used, and so any opportunities to partner with guideline groups would be of great interest.
Great. Thank you for that. A question for the group from one of our attendees is about clinical trials, particularly if anybody has any knowledge about any devices used to treat migraine and any clinical trials that are going around that, or any thoughts on migraine devices to help patients.
This is Lindsay. I can certainly say that, number one, as I mentioned, we're always supportive of more treatment options being available to migraine patients. Number two, we don't serve as a clearinghouse for clinical trials awareness, but there are groups that do, and I'd be happy to provide information after the call about ways that folks can get plugged in and be on a list of notifications. We know that there are devices out there that are effective for migraine patients, and so we encourage folks to use and avail every treatment option to them.
Great. Lindsay, I know both you and Alicia talked about Headache on the Hill. So where can attendees find out more information about the one coming up, and how would they find out more information about how to be engaged?
Sure. Alicia, do you want to take this one, or do you want me to?
No, you can go ahead and take it.
Okay. So to be clear, that's run through the Alliance for Headache Disorders Advocacy. And while there maybe on this call listening, they run that event. And so I would go to their website, allianceforheadacheadvocacy.org. I do know that the application process, which is pretty robust, has ended for this year because it's coming up in about 2 months, and so a lot of travel arrangements and health scheduling has to occur. But in order to get in the queue, the person to contact would be Katie McDonald, and she runs that effort. But I would start with their webpage to learn more about the event and look at the gallery photos, etc. And then I would also encourage people, the event goes from February 11th through 12th. The actual Hill Day is February 12th, and there will be a designated hashtag on Twitter, hashtag HOH2019, that I would encourage people to kind of track to see if it's something that you think looks interesting and you'd like to take part in the next year.
And this is Alicia. I just have another point to add. And I don't know if any states are underrepresented. So if anyone is interested in going, it may still be worth possibly reaching out in the event that there are any states that are not filled up.
Great point.
So this last question is for the group as a closing thought. We talked quite a bit throughout the webinar about some of the challenges that migraine patients are facing and researchers and barriers with prescribers and challenges there. I just wanted to close and maybe if each of you can just share some of your thoughts about what you're optimistic about in the coming year that your particular group will be pursuing to help migraine patients improve their overall quality of life.
So this is Alicia. Personally, I am so hopeful for these other therapies that have just recently come to market and the ones that are about to come to market. Some of the therapies that are out there haven't helped people yet, but there's just so much hope that these the next ones that are coming out really might be able to help people. And secondly, my organization, the Association of Migraine Disorders, is really working on research this year with our research roundtable, really getting involved in the Society for Neuroscience. And a big goal for us is trying to get more people interested in studying migraine from a research standpoint, but also getting involved from a clinician standpoint.
And this is Lindsay. I would just add that, even for the options that are on the market but are rather new, I'm excited to see storytelling. I'm excited to hear, in some cases, patient success stories, because we know for some patients the therapy may not work until it's been utilized for a certain period of time. And so, whatever migraine freedom means for patients, I would like to hear some of those stories. And so we're working with the patient member groups of our organization to identify people who have had positive experiences to really talk about how life-changing it could be. And so I think moving ahead, that increases awareness, it decreases stigma, and having more people speak out raises the profile of this disease so that activity begets activity, I guess is what I mean to say.
And I'm really excited by the new clinical decision support tool that was created. It was, just to be technical, it was created in HL7 and in EPIC, but we hope that it will be interoperable across a number of healthcare, number of EHRs, and that physicians will implement it and offer better care to their patients by taking into account all the variables and parameters that are needed to make a good decision to help a patient who's in pain.
Excellent. Thank you so much. And we just want to say another special thank you to all of our panelists today for generously sharing your time. We know you have busy schedules, for sharing your time with us, and for all those who tuned in today to listen to the program. We hope that you have a wonderful rest of the day, and that includes our program.
Thank you so much.
Thank you very much, everyone.